Growing up, I knew my parents were there for me. We celebrated family events. They were there for me when I was sick or needed help. As me and my sister grew up, we knew we could count on our parents. We were so proud to be their children. Today, we are there for our parents, to share in the celebration of their grandchildren or to be there when they are ill or need assistance. They can count on us. And now our parents look to us to take care of them. Hello, and welcome to Always There. My name is Michael Wilsker. I'm Vice President of an elder care company called Always Best Care Senior Services. We provide in-home non-medical care. And today we're going to be talking about another issue that's faced by elders and their families. We're going to be talking about in-home non-medical care private agencies. And my guest today is Howard Goldstein, who is my partner and president of Always Best Care Senior Services. Welcome, Howard.
Thank you so much, Michael.
To explain to the people that are watching, what is the chief function of a in-home non-medical care agency?
I would say the primary purpose is to allow seniors to remain in their homes by providing care to help them remain safe and sound, to stimulate them mentally, physically with exercise, whatever, but designed to really keep them healthy and at home. Most seniors do not want to go into a nursing home. That's a primary consideration, and the healthier they are at home, that can delay as long as possible admission into a nursing home.
Do you find that most elders want to stay at home, or is that the predominant behind that, is that most elders want to live at home?
Absolutely. If you did a survey, probably well, if you asked how many would want to go into a nursing home, I think that would be zero. I don't know of anybody in the years we've been doing this who've aspired to move into a nursing home. It's just not what people like. People like their surroundings. They like the memories, their children growing up, holidays, events. So if they can stay at home, that's certainly what they'd like, most of all.
And then there's a small portion that would, who can't live at home for whatever reason, and they go into assisted living or independent living.
That's correct. That's
correct. Do agencies then provide care in those residences?
They can. An assisted living community generally has their own care people that are employed and available, but there's limitations at times as to how much care can be given. So there's always an opportunity, and many times, for an agency to provide supplemental care within a senior or assisted living community.
And what types of people that agencies hire to take care of the elderly in their homes?
Sure. The non-medical in-home care industry, which is what the subject of this show, this conversation, generally provides care. Most of it is rendered by CNAs, certified nursing assistants. There's also folks, they're generally called PCAs, personal care attendants. There's home health aides. There's a gamut of people with that skill. They're not registered nurses, therapists. They provide help around the home, but they have skills. They have knowledge of issues of the elderly, of aging, of proper nutrition, of cleanliness, hygiene, transferring skills. So they have a good knowledge of skills that can help the senior remain safe and provide quality of life for them.
What is a transfer?
Transfer could be several things. The most common, I would say, would be getting someone from a bed, perhaps they have a hospital bed in their bedroom, safely either into a wheelchair or maybe helping them with a walker. Again, depends on the mobility issues. There are also lifts known as Hoyer lifts. That's generally something that's not done in a private setting. There's, as a rule, it's a little bit more complicated. Generally can require two people, and something you don't really see much in the home setting. It's generally assistance from a bed to a walker to a nurse to a wheelchair. Excuse me.
And is it just the CNA qualified to provide that kind of care, or is it can a companion or a healthcare home health care person do that, or should be a CNA?
It can be a home health aide. Without getting into the specifics, the CNA is generally the most trained of the designations that I've mentioned in that field. The home health aide is somewhat less, but they're trained in that. Again, it has to be properly assessed and determine what's needed. You know, it's always case by case.
And how do you determine what kind of care is necessary for the elder?
Well, we obviously meet the family, meet the elder, look at the environment, look at the needs. Depends on the number of hours that the family wants care. So we have checklists, analysis forms when we do the assessments. We just no case, no family situation is the same. Everyone is different based on the needs, how we can provide care, what the family's budget is, things along those lines.
And do you typically go over the house and sit with them there? And,
Oh, absolutely,
yeah.
absolutely.
And do you find that most of the referrals that you get are, or the people that are more interested are as the family as opposed to the senior themselves?
Generally, that's true. Most seniors tend not to think they need help. They're pretty hardy folks, don't want to be a burden on their families. Generally, a child, usually a baby boomer, will be the point of contact. They perhaps are feeling burnt out. They have a job, the spouse, children, other issues, and the parents can be more demanding. They need more care. They're putting more of a strain on the child or children, and that person generally gets to the point where they need some help. They know they can't do it all, and the parent needs assistance. And that's
So sometimes that help is, the aide comes in there to really give relief to the caregiver, to the family caregiver, is that right?
Yeah, sometimes we care for two people, the actual senior who we're doing the hands-on care, but also psychologically for the child, if you will, because we're now allowing that person to have more personal time, to know that mom or dad is being taken care of while she or he is not with a family member. So that's important.
Now, when you have the assessments, when you sit down with the family, you determine what you can do for them in the home, but do you also tell them, well, this is not the proper place for them to be? We think that they should be in an assisted living or even have to be in a nursing home. Do you give that type of advice out as well?
Absolutely. There's times where we're just uncomfortable. Perhaps the house itself may not be properly safeguarded. The individual may be in such poor health that it would be problematic if we can help them or help them to the level. We obviously want to care for families, but we don't, and using the whole home care industry, profession, field, we all are looking out for the family's best interest.
Now, do you help them coordinate services, or say they need a handyman or they need other things in the house to make it safer for the senior? Do you try to put that together for them, give them reference information about different
Oh, certainly.
companies within
Yeah.
that industry?
We know a number of people in a variety of senior-related areas, things like Lifeline type devices, folks that are in the modification field where they can put ramps and safety grips, things like that, and a number of folks, another number of people that are in subspecialties, and we certainly know many of them. We would offer names as referrals. That's part of what we can do. It doesn't always happen on every situation we're in, but we have those resources available at our fingertips.
Talk about how the in-home non-medical care agency works with visiting nurses, therapists, whether it be physical therapists, occupational therapists.
Sure. Probably a little background or stepping back, a little bit of definition. What we are, the non-medical in-home care, is we're not for lack of words or for better or worse, a visiting nurse association or certified home care agency. Those are agencies, entities that provide registered nurse services physical therapists, occupational therapists. They are generally prescribed by a physician. So a case would be someone is in a rehab center after having surgery, maybe hip replacement. The physician determines that when the when this patient is discharged, that they're going to need additional care. So they'll authorize so many hours a week of nursing visits, of therapies. Those are paid for generally by Medicare and or private insurance. The non-medical in-home care industry does not require a doctor's authorization. It's a private engagement, a private contract, if you will. A family needs services and they'll pay for it. The payment, by the way, is either private pay or direct bill or reimbursement from long-term care insurance policies. So we don't bill Medicare or Blue Cross or any of the myriad of insurance companies. It's strictly a private, non-medical relationship.
Okay, so if there's ever a crisis with the senior, does the in-home care non-medical caregiver provide any type of medical assistance? What takes place if that was to happen?
Generally not. I mean, as our philosophy, and it's speaking more for ourselves than other agencies, but I would trust it's similar, is we tend to realize we're not a physician, we're not a nurse. We will strongly dial 911. We'll request emergency care. We really are there to provide comfort and to the family, but we're not licensed as nurses and as a certified agency. I'm not sure if that's what you're...
No, I understand it, but what I didn't ask you this before, but what about hospice? How does that work with an agency, with a private agency?
We can provide supplemental help. Hospice is a service, end of life, prescribed by a physician. Care could be in home. Actually, if a person resides in an assisted living community, hospice care can be provided there. It can also be provided in a nursing home within a hospice setting. It provides care end of life. It's not designed to extend life. It's to reduce pain and suffering and sort of end of life comfort. Where a non-medical in-home care company would come in is that the normal home care component of hospice, paid for by, say, Medicare or Blue Cross, is limited in the number of hours per week. And a family may feel that they need more care. It could be as much as 24/7 care during those last days or weeks.
Well, can you also talk about what types of care is paid for by the state or by nonprofits to help people stay at home?
Sure. There are certain publicly paid sources of in-home care, and one of them is offered by entities such as BayPath. They're nonprofit agencies that are funded by the state. They, based on the financial situation of a resident, they can provide generally limited amount of care.
What do you mean by limited?
Generally 2 hours a day, maybe 3 days a week. I don't want to speak for them. Obviously, they have their own assessments and guidelines, but through our experience, by and large, they seem to be limited number of hours. So it's certainly a valuable service, but it's also generally limited. It wouldn't cover enough hours to really provide adequate care for an individual to remain at home. But again, that's based on an assessment and the needs of the family.
Now, we were talking about that agencies provide most of their care at home, but they also provide the care we talked about before in assisted living. But what about independent living? The term is that's bandied about is aging in place.
Correct.
Can you talk more about that?
Well, that would be like most things. There's no exact cookie cutter approach, but most senior residences are less care offered than assisted living. Assisted living would generally have 3 meals a day and the availability of home care aides. A senior residents may have some meal plan available, some social situation, social component, but there's very little, if any, care offered. So if a person is getting older, needing more assistance, then they would need presumably care for in-home care. We would see that would be offered and available, and again could be from a limited number of hours per day or week to significant hours based on the need and the affordability, the resources available.
Now, how do they find out about you? Would they go to somebody within the independent living residence and say, the daughter goes over to them and says, we want our parents to stay at home. We don't, in the independent living, we don't want them to have to go to assisted living or into a nursing home. Does the facility then give them a range of agencies, or how does that work?
That's generally correct. They would, perhaps a nurse or a coordinator, depending on the residents, who they have, they would have available their a list, an inventory of home care agencies. So we obviously try to get onto a list. We tried to provide high quality service, or any agency would. Obviously, I'm speaking in general. Everybody's trying to do a good job, and hope to get more referrals. There's a.
So independent living residences and assisted living have their own nursing staff, or how is that?
Assisted living communities do have a nurse on staff, but generally not providing hands-on skilled nursing. It's the nurse on staff is providing comprehensive assessments, record keeping, and regularly scheduled reevaluations. Because when a person is going to move into assisted living, a care plan is set up from the beginning, and that's monitored on an ongoing basis. And there's usually every, say, 6 months there would be a reassessment, and that they use nurses for that purpose.
And what about nursing homes? It's my understanding that when some elders go into a nursing home, they come out of the nursing home and they go back home, and they get care there, and then maybe go back after that to go back to the nursing home. Is that is that a situation that takes place?
Yeah, nursing homes, I guess, could be divided into two components. One would be a rehab component, where that would be somebody who was in a hospital for surgery or an illness, not quite ready yet to go back home. So they go into a nursing home that has a rehab unit, if you will, and they receive therapy, physical therapy, occupational therapy, additional time to get back on their feet. At that point, at some point in time, they're ideally sent home and able to resume their normal life. Then you have cases where folks are what we call long-term residents of a community. Generally, that would be someone who's getting well up in years, but not always. I, for instance, have a sister who's in her 60s who's a resident of a nursing home. She has severe multiple sclerosis. She's unable to care for herself. So even though she's a good 2 decades younger than the average resident of her nursing home, she needs to be there. And she's also at this point covered by Medicaid because she was unfortunately had to exhaust her resources due to the expense of a nursing home.
So an in-home care service also provides services for people that aren't elderly, is that correct?
Oh, yes. We've done care for folks with multiple sclerosis, other neurological diseases. Those are sad, but unfortunately that is a fact of life. But our typical, and I would think across the spectrum, the typical client is a person in their mid to late 80s who's just at this point needs assistance with bathing, transferring, dressing. They could be incontinent, need help with those issues. Also meal preparation, light housekeeping, things of that nature. So it's a really nice comprehensive service based again on the needs of the particular individual, but it can allow that person to live with dignity and much pleasure.
Do agencies provide transportation as well?
Certainly, there's always that opportunity. Care providers, most of them do have automobiles. We have a thing where we can either drive the the client's automobile or our own care provider, we're obviously fully insured and require insurance from the client if we're going to use their vehicle.
So they say they drive them to a doctor's appointment. They bring them into the doctor's office. They don't. Do they advocate when the doctor meets with them, or is that part of what they do?
Generally, no, but if it's just a driving service, on occasion we'll just be called to do a driving service. At that point, we don't really know the family. It's not our responsibility or our knowledge to participate. But normally, if we have a situation where we're providing a good number of hours per week, we're quite intimate with that individual, with our client, and our care provider can bring the physician or the nurse up to date on certain trends. Maybe their health is getting worse or they're seeing improvement, whatever the case may be. Certainly, they know the client, they know the patient, the individual. That's certainly allowed and encouraged.
In my own experience with my father down in Florida, he was in a hospital, and he was transferred to a rehab, and then from the rehab, he went into nursing care. In the rehab and in nursing care, my mother, who had enough funds, was able to hire private nurses, private caregivers in the rehab to supplement the care that they were getting from the nurses at the facility, and then the same thing held true at the nursing home. Have you had experience with that, or is that common, or usually it's very, very uncommon because of the cost involved?
Yeah, it's not very common. We've had a few in the past where we were bringing in, and it had to be a CNA licensed in the state, working under almost the authority, or at least the co-authority of the nursing home. So there is some hurdles there. The reason was this person was providing bathing and transferring, doing the services that would normally be provided by the staff within the nursing home. But we've had other situations where we've brought somebody in more as a companion, and that's a lower threshold, just somebody to perhaps play cards with an individual, to have a conversation, a cup of coffee, something like that. That's really more of a hired friend, if you will, so right. That's different.
And what about, how do people, what kind of fund payment do you take? Is it all private pay? Is there any Medicare, Medicaid to pay for it, or what are the
okay,
kinds of payments?
Private pay is the primary vehicle, if you will, just an invoice sent out on every other week in this case, payment received. We also can either directly bill long-term care insurance companies or submit for reimbursement for the client. Will do that, the applicable paperwork, so they will get reimbursed. As far as other sources, no, we can't get paid by Medicare or private agencies, private insurance companies.
Right.
But there is another method that's fairly common. It's through the VA. It's called the Aid and Attendance Program, and that's it's a pension for veterans who served during wartime. Didn't mean they had to be on a battlefield, but they had to serve during a conflict. They were, I believe, generally discharged, not dishonorably, generally or honorably discharged, but not dishonorably discharged. And they meet certain income and asset guidelines. And they can receive, I think the minimum, and I haven't looked at it in a while, I'm going to say about $1,300 a month tax-free. And that money can be used for things such as home care. It can be used for other medical related, but it's there. It takes a little while to have done. It's a whole other sub issue, but that's available and is being utilized quite a bit.
How do they find out about that? Is that general information that they get from the VA, or how does that work?
You can call the VA. They can provide the information. It's from what I gather, that it's about a 6-month process for approval, but you will get a retroactive check. It's almost a whole other subspecialty. I do know of some people that specialize in that. We don't get involved ourselves in the process, but there are people that have made a certain specialty in it.
Right. Time being what it is for the show, I think I'll be presenting somebody, having somebody here to talk more in depth about that program.
Okay.
How does, from what sources does a in-home care agency get its clients?
Many sources. We get referrals from social workers at nursing homes, from people who work at assisted living communities, senior centers, just through marketing, through meeting people, through networking, BNI. We get referrals from, obviously those are the best referrals are from people who discuss with our satisfied clients. We've received several. We also, many of the long-term insurance companies have their own third-party administrators, and we're on lists there. We get referrals from our website from other people. So it's a very broad range of ways where we can get introductions to people, and we will quickly go over and see how we can help them.
And just explain to everyone what the difference is between hiring a caregiver from an agency as opposed to just like going on the internet and finding a person who does it on her own.
Sure. We hire our caregivers. They're our employees. So we cover them. Their payroll taxes and unemployment taxes are covered. Workers' compensation, excuse me, insurance is covered. So when a family hires our agency or others in this case, they will be not having to worry about taxes being paid. They don't have those responsibilities. An agency such as ours also carries over $1 million of liability insurance. So heaven forbid something goes wrong, we're fully insured. A private care person, let me just step back. We also run criminal background checks, so we are very careful, and we do screening and interviewing. So folks that come on board have been vetted, and we also provide training. We do hire experienced CNAs and other care providers, but we also provide orientation and ongoing training. If you're hiring privately, you get what you see. You don't know if that's always what you're getting. So you know that we've done a lot of work before we put somebody on in a family.
Well, that's great, Howard. I think you've really ran the gamut about what is out there and how an agency works. And I want to thank you for coming here and sharing that with everyone in Westboro.
Okay, very good. Pleasure being here.
Thank you. So that's our show today. I want to thank you all for viewing, and we look forward to seeing you next time on Always There.